Good afternoon, students. Today, our lecture topic is pharmacokinetics. To get a basic comprehensive idea about how the drug works, we have to be master on pharmacokinetics and dynamics. We have two lectures for kinetics and then again two lectures for dynamics. So altogether, 4 lectures. These are very easy concept, but you have to understand it very thoroughly to make your journey easier in life of pharmacology and to pass the exam easily. Hope you all can see the screen very clearly. And as you all know, I'm Dr. M I M Shuja, and this is Pharmacokinetics Part 1 lecture. So what do you understand by pharmacokinetics? Basically, pharmacokinetics is what the body does to the drug. Imagine you got a fever, a cold, or upper respiratory infection. You are taking a drug. The moment you put the drug inside your mouth, if you are taking that orally, what are the series of events happening for that drug until it reaches the site of action or until the drug is fully eliminated from your system. So basically what the body does to the drug is pharmacokinetic. What the drug does to the body is pharmacodynamic. That's it. So when you take, imagine when you are taking a tablet orally, you have to swallow it. Then it will have some reaction with your saliva. Then it goes to your stomach. Stomach is acidic. So it again undergoes some kind of changes, chemical reaction. Then it goes to the duodenum and small intestine. So where it gets absorbed from the gut. Before it gets absorbed, it should come to a solution form. The tablet you are taking is a kind of solid. So with the things happening in the GI tract, it comes to a solution form. And it reabsorbs in the gut lumen and it goes to the liver first via the portal system. And from the liver, it goes to the heart via inferior vena cava. And from the heart, it will go to your systemic circulation. In systemic circulation or via systemic circulation, the molecules or the drug component reaches the site of action. Then once it's the work is done, it will return via the circulation and either go to the liver or to the kidney or again from the GI tract, it got eliminated from your body. This is the basic kind of event happen for the drug. Know that. In the pharmacokinetics, we will see all these events in detail. From the moment you take the drug in till it eliminated from your body. Okay. So pharmacokinetic is currently defined as the study of drug absorption, distribution, metabolism, and excretion. All these four we call sometimes ADME: absorption, distribution, metabolism, excretion. The first initial word of the initial letter of these words we put for our easiness and we call it ADME. So you can easily remember. Then what is clinical pharmacokinetics? It is the application of pharmacokinetic principles to the safe and effective therapeutic management of the drug in an individual patient. The purpose of studying pharmacology is not to know what are the drugs in the world. Who cares? When you are treating your patient, you have to give them effective dose as well as safe dose. To give that as a future MBBS qualified doctor, you should know pharmacokinetics. Okay? So that is the purpose of I am teaching pharmacology and you are learning pharmacology. Of course, you need to pass the exam, that's a different story, but in the view of treating patient, this is very important. So whenever you combine all the drugs into a safe and less lethal form, it will come like this. If you are a chronic patient who are taking 10 or 15 tablets, if you see few patients who are aged, not only elder patient, the few people who got combination of multiple comorbidities, they are taking 10 or 12 drugs per day. So lot of interaction among those drugs, lot of side effects, and lot of issues. If you know the pharmacokinetics, you will make their life easy. This is just a cartoon to make you all smile. You can smile. So pharmacokinetics, I told you, admit all the four components. The first one is drug absorption. The transfer of a drug from its site of administration to the bloodstream. So usually the drug crossing the biological cell membrane. Cell membranes are made of lipid bilayers. So lipid soluble drugs will go through the cell membrane easily. So there are few mechanisms of drug pass across the cell membrane, like you know in your early physiology: passive diffusion, facilitated diffusion, filtration, active transport, and endocytosis. A large molecule like vitamin B12, as far as if I am correct, that is across through or via endocytosis. So the water soluble drugs, they go through the aqueous channels as a passive diffusion. Lipid soluble drugs goes through or across the cell membrane in passive diffusion. And there's a carrier mediated active transport mainly for the water soluble drugs, because the cell membrane is lipid soluble, so lipid soluble drugs goes through easily, for the water-soluble drugs to cross or go through the cell membrane, you need special carrier proteins. The passive diffusion, as you all know, you are our proud physiological students. Any drug moves passively from an area of high concentration to low concentration. ATP is not required. Filtration, like what is happening in your glomerular filtration, aqueous channels in the tight junctions between adjacent epithelial cells allows a passage of some water-soluble substance. They mainly depends on the molecular size and the weight of the drug. If the drug molecules are very smaller, they filtered easily through the membrane. In the carrier-mediated transport, what actually happened is there are carrier-mediated transport channels in your body for body's own endogenous ligand. So when you give a drug that resembles similar structure to that natural constituent, those drugs will utilize the same mechanism. Okay. For some carrier-mediated transport, you need ATP. Others, they don't need. So that is basically what are the modes or what are the ways your drug will go across the cell membrane. The movement of drug from the site of administration into the bloodstream, that is drug absorption. Okay. Either you take via oral or give IM or you give subcutaneous or intradermal, whatever, or per or whatever the site of administration, ultimately your drug has to get into the bloodstream. So there are few factors affecting or influencing your drug absorption. The physiochemical properties of the drug, that is basically if the drug is lipid soluble, it go across the cell membrane very easily, and the route of drug administration has a important thing, because if it is bypassing your portal circulation, the more drug will come to the blood. And the pH and ionization, presence of food and other drugs, and few other factors. We will go into detail. When you take the physiochemical properties of the drug, again, the physical state of it, whether it is lipid soluble or water soluble, whether it is ionized or unionized, what is the size of the particle, whether it is small or large, what is the disintegration time, what is the dissolution time, and what formula is it. That means the few drugs to make it more efficacy or to keep them without disintegration, what we do is we add some other chemical. So sometimes those chemical has an effect on their physical properties. So if the drug is liquid, it's better absorbed than solid. If it is lipid soluble, it easily go through the cell membrane. If it is unionized form, it is again easily go through the cell membrane. And if the particle size is small, it will go through easily. The disintegration time is the time taken for your solid drugs to get crushed. The time taken for the formula to break up into small particles, that is disintegration time. Dissolution time is the time taken for the particle to go into solution. So the shorter the time, the better the absorption. Then route of administration. So there are a lot of enteral, parenteral, and other routes, lot of routes. I think by now you should know the route of administration in detail, but anyhow I will go through. So in enteral, either you can take by via mouth or sublingual, which is below the tongue, buccal, between the tooth and the buccal, and via rectum. Parenteral, either you can give IV, IM, subcut or subcutaneous, or inhalation. And there are other routes: intrathecal, intradermal, intranasal, intratracheal, and intrapleural. Okay. The advantage of giving IV is the IV route bypasses the whole process of absorption. Okay. So we saw the absorption is basically the drug which you taken has to enter the bloodstream. So if we are giving IV, directly the drug enters the bloodstream. So it bypasses the process of absorption. Drugs which are highly polar and ionized in solution. That means polar and ionized mean it is mainly water soluble. Not always, but mainly. So water soluble drug, it will difficult to go through the cell membrane. So to avoid that, these kind of drugs, the drugs which are highly polar and ionized in solution, we give as IV. And absorption from the gastrointestinal tract. The small intestine is where most of the drugs get absorbed. Even though stomach is acidic and where the gastric stomach is acidic. So the weak acid drugs which are non-ionized in the acidic pH and lipid soluble drug, according to the theoretical knowledge, they should traverse easily through the stomach, but it is not happening the way we think. Okay. The factors affecting gastrointestinal absorption, the gut content. If you have any other foods or other drugs which has some interaction with the particular drug, the absorption is affected. If you are having diarrhea, your gastric model is too fast. You don't have enough transit time for absorption. So there's a problem in absorption. Imagine you are having constipation. Your transit time is too slow. So you will absorb too much of drug. Okay. So these all will influence the absorption. So these factors will influence the pharmacokinetics, because absorption is one limb of the pharmacokinetics. The pH and ionization, this is very, people think it is a very difficult concept. No, it is very easy. Listen carefully. Strong acid and basic drugs always remain ionized at all pH. So when they are ionized, that means water soluble. So it is enabled to go through the cell membrane, that is lipid. That is favorable the lipid soluble drug. So strong acid, strong basic drug, they are remain ionized at all pH. So they are poorly absorbed. So better way to give them is IV or other means, not the oral. Weak acid. Imagine the gastric acid and the early part of the duodenum, they have acidic pH. So weak acid drugs in the acidic pH, they are in unionized form. Unionized means not water soluble. They are lipid soluble. So they can better absorb from the this part of the early part of the duodenum and the late part of the stomach. Weak acids are unionized in acidic pH. Like that, weak basic drugs are unionized at alkaline pH. So where you get alkaline pH? Small intestine. So at the small intestine and in the alkaline pH, the weakly basic drugs are unionized. So they are better get absorbed here. So examples of weakly basic drugs are morphine and amphetamine. Weakly acidic drugs are aspirin and barbiturate. So aspirin is better absorbed at stomach. That is true. If someone say morphine is better absorbed at stomach, that is false. So you should know weakly acidic acids are better absorbed at stomach. Why? Because stomach is having acidic pH. So weakly acidic drugs are unionized at acidic pH. When there is unionized, that means it is lipid soluble. So you can traverse through the cell membrane. Not all unionized compounds are lipid soluble, but for the understanding purpose, we came to a conclusion like that. Whenever there is polar, it goes with ionization and it goes with water soluble. Whenever there is non-polar, that is unionized, that goes with lipid soluble. Remember that it is very easy. And the food. So like rifampicin, paracetamol and levodopa, when you give those drugs with food, the reabsorption is low. That's why you ask to take them at the empty stomach. One addition to this is thyroxine. Thyroxine also we ask the patient to take in the morning in the empty stomach. Okay. Few milk products decreases the absorption of tetracycline. Fatty meals increases the absorption of triacylopyrin. Presence of other drugs like ascorbic acid increase the absorption of iron. And if you have pernicious anemia, your vitamin B12 is not absorbed due to the lack of intrinsic factor. So you have to know few examples for each incident. So when you have better area for absorption, you will absorb more drugs. When you have disease in your GI tract, you may not absorb enough. So this is just an overall idea. You get a dosage form and you are taking in via oral. There's a disintegration. We know the large particles become small particles. Then in the GI tract, it becomes solution. So that is dissolution. and solution is reabsorbed or absorbed and goes to the blood. And from the blood, it will either bind to albumin or it will not bind to albumin. Then it get distributed to the overall part of the body. So the distribution we will look in later. And this bounding part also tricky. I will make you clear in the following lesson. So what is bioavailability? Bioavailability is denoted by capital F. It is the fraction of the drug that reaches the systemic circulation from a given dose in an unchanged form. Imagine what is our absorption? You are giving something oral. For example, if you are giving something orally, that drug has to reach your systemic circulation or the blood. So imagine if you are giving a drug 100 gram, but only the 70 gram is reaching the systemic circulation. Then what is the percentage? 70 divided by 100, 70% or 0.7. That is bioavailability. So these are definitions. You have to remember, or without by hearting the definition, you can write in your own understandable manner in a simple English. Either way is fine. So if you are giving IV, you are directly giving all the 100 grams of drug into the blood. So you are giving 100, the blood also 100. So bioavailability is 100. So intravenous route, the bioavailability is 100. If the two formulation of the same drug produce equal bioavailability, imagine we have the oral, we have the IM preparation, both give same bioavailability, then we call it bioequivalent. If it is differs, we call it bioinequivalent. So you give a drug and you measure the plasma concentration of drug in the blood. You will take serial measurement from time to time. Then you plotted this plasma concentration and time in the x-axis and y-axis. Then you will get a graph like this. Okay. So they said it measured by determining the plasma drug concentration versus time. Curves in different group of subjects following oral and IV administration. So this is the IV administration. See, it quickly reaches the maximum. We can so here we may ignore this small time period and we can take straight away it reaches here. So from the time it got the peak, with the time its concentration is going down very smoothly. This is for your IM. This is for your oral drug. So if we want to say the bioavailability for each thing, we have to calculate the amount of drug which is reaching the venous. So for that we calculate area under the curve. This is the ideal, right? The intravenous, the bioavailability of if you this imagine, these all three routes are for the same drug. So if you are giving in IV form, that is 100% bioavailability. So the area under the curve will give you the concentration of drug. This is oral. So the area under the curve will give you the concentration of oral drug. So if you are going to say the bioavailability for oral drug is the bioavailability F is area under the curve of oral divided by area under the curve for IV. Okay. This is how you are calculating the bioavailability of a drug. My little one is coming, and you know, as you all love me, my little one also loves me very much. Okay. Okay. Sorry for the interruption. My little one is there. So now you know how to calculate bioavailability, but don't worry, we don't ask you to calculate bioavailability. Know what is bioavailability. Bioavailability is simply the fraction of drug that reaches the systemic circulation from a given dose in an unchanged form. Whether it is oral, IV, IM, subcut, whatever, what is the fraction that reaches the systemic circulation? That is bioavailability. The factors affecting bioavailability. So that means the factors which is going to affect your drug reaching the systemic circulation. The first pass metabolism, hepatic diseases, enterohepatic circulation or cycling, few pharmaceutical and biological factors. What is enterohepatic circulation? This is physiology. I hope you remember that. The circulation of bile acid, bilirubin, and drugs from the liver, they goes into bile. Then they enter the small intestine. Then again, they absorbed or reabsorbed by the enterocyte, and they goes to the portal circulation and go back again. Several drugs from conjugates with glucuronic acid in the liver, they enter bile acid, then delivered to intestine. Glucuronide then get hydrolyzed, regenerate the active drug. The active drug, that means the free drug, reabsorbed and cycle is then repeated. It is result in a reservoir of recirculating drugs that can amount to 20% of the total drug in the body. So when there is enterohepatic circulation, the drug, they got glucuronide or conjugated again form into the previous active form. So you will have more active drug for the certain concentration or given concentration of drug. So when you have this kind of regeneration of the drug, you will have more dose of drug. So your action will be prolonged. Okay. Few important examples are morphine, ethinyl estradiol, lignocaine, propranolol, chlorpromazine, all have enterohepatic circulation. So you give drug, it goes to the gastrointestinal tract, and via the portal system it goes to liver. And few things will via enterohepatic circulation again get into the liver. So from the liver it goes to the GI tract. Again from the liver it goes to the tissues. There's the enterohepatic circulation adding more doses. So what is first pass metabolism? It's again a very interesting concept. First pass metabolism is when the drug passes the liver first time, it got metabolized. After oral administration, before it reaches the systemic circulation, all the drugs are get absorbed into the liver. So from the liver, they undergo metabolism. And from there, it reaches the blood. So that when it get metabolized in the liver, amount reaches the blood is reduced. So that is first pass metabolism. After oral administration, certain drugs, they undergo extensive metabolism in the liver. Therefore, decrease bioavailability. In severe hepatic failure, the first pass metabolism is reduced or not there. So your bioavailability is increased. So when there is too much of bioavailability, then you expected normally, it will give exaggerated response. That is toxic effect or serious side effect or adverse reaction. So here your drugs comes the GI tract. From GI tract, it has to go to the systemic circulation. Before reaching systemic circulation, it get metabolized in the liver. So the rest is reaching the systemic circulation. That is first pass metabolism. What is absorption? The drug which you taken via oral has to reach the systemic circulation. Before reaching the systemic circulation, it got metabolized in the liver. So the amount is reduced. That affects the bioavailability. So there are few examples of drug with first pass metabolism and the particle size, tablet size, diluting substance all have an effect on that. And the presence of food because of the diarrhea or constipation, the rapid and slow absorption, destruction of gastric acid, all will have an effect on your drug absorption. Okay. With that, drug absorption is done. Then we'll move to the drug distribution. So drug distribution is reversible transfer of drug between body fluid compartments. So what is drug distribution? Now we have taken something chemical or some drug. Now we have taken it via oral, IVO, IMO, any route. Now the drug is in the systemic circulation, in the blood. Now you are going to distribute that drug into the body compartment where it has to go. Either it has to go and act, either it has to go and store, or it goes and metabolize or whatever thing. So that is distribution. So how you are going to distribute the drug, we're going to see. Basic definition is reversible transfer. Okay, the word is very important. Reversible transfer of drug between body fluid compartments. So you have three kind of, mainly extracellular, intracellular, then among that there is a transcellular. So this is the normal distribution. We have seen enough of this in the physiology. In the extracellular, you have plasma, interstitial, and transcellular fluid. The plasma is where now you are having your drug. From here onward, it either goes to this compartment or to the ICM. Reversible means even from these all three compartments, at one point, it may come back to the blood. Lipid-soluble drugs reach all compartments and may accumulate in fat. Lipid-insoluble drugs, that is water-soluble ones, are mainly confined to the plasma and interstitial fluid. And I am going to introduce a different concept. People believe it is a very difficult one. No. This is again one of the very simplest concepts. Okay? Volume of distribution. It is a hypothetical volume. That means there is no such true volume in your body. To make our life in pharmacokinetics easier, we created this. Okay? It is the hypothetical volume of body fluid into which a drug is uniformly distributed at a concentration equal to that in plasma, assuming the body as a single compartment. So this is the equation for that. The total amount of drug in the body divided by concentration of the drug in plasma. Because when you give a drug, it reaches the plasma. Then from plasma, it goes to the all the compartments. But we only know the concentration in the plasma. So if we know the total amount of drug we give, imagine, then we divide that by concentration of drug in plasma, and we assume in other all the compartment also the same concentration prevails. Then it will give you a number, that is the volume of the distribution. I am going to make the definition bit easier now. The volume in which the drug appears to be distributed if the concentration throughout the body were equal to that in the plasma. This is more easier, right? This definition also correct. Volume of distribution is theoretical value that represent how extensively a drug is distributed throughout the body. Now, what do you understand by increased volume of distribution? The drug is distributed throughout the body extensively. What is reduced volume of distribution? The drug is not distributed extensively. It is confined to the systemic circulation or plasma itself. High volume of distribution or large volume of distribution is the drug distributed throughout the body. Low volume of distribution is the drug is confined within the blood vessels. In between, the other category will come. It often represents as kilogram of body weight. So that means the volume of distribution is measured in liters of plasma per kilogram of body weight. If a drug remains mostly in the plasma, the volume of distribution is low. If a drug remains mainly in the other drugs, the volume of distribution is large. So there are few drugs, you should know the volume of distribution. Aspirin volume of distribution is 0.1571. It is 0.1. Pethidine is 280. See, this 280 is more than the normal body fluid in your body. So, what does it say you? Normally, we have fluids in our body that we can maximum how much? What is the normal water in your body? In an adult average 70 kilogram person, it is around 42 liters, we assume. Okay. But here, this is 280. That's why I told earlier, volume of distribution is hypothetical. It is not really exist in your body. It is just a hypothetical volume to make your life in pharmacokinetics easier. That's it. So aspirin is volume of distribution is low. So it will stay inside the blood vessel or plasma. Pethidine volume of distribution is too much. So it will be found in the other part of the body, other tissues as well. So if you are going to do hemodialysis, which drug will get eliminated easily? You are doing hemodialysis, that means you are purifying the blood. So aspirin and pethidine, mainly aspirin is inside the plasma or blood because it has very low volume of distribution. So via hemodialysis, you will remove aspirin successfully. You may not be able to remove pethidine successfully. Okay. So what are the factors affecting drug of distribution? Volume of distribution, physicochemical properties, degree of plasma protein binding capacity, capillary permeability, blood flow, tissue storage, disease of the tissues and fat. When there is a lipid soluble and unionized drug, they easily cross the cell membrane. So they are widely distributed like lignocaine, propranolol, TCAs. Heparin is found in ionized form. What is ionized? Water soluble. So it is confined to the what? IV compartment, your plasma. So volume of distribution will be low. Degree of plasma protein binding. In the plasma, you are having plasma protein. So when a drug is bound to the plasma protein very attractively or highly, that means that drug is stays inside the plasma. So it may enable to distribute to the other part extensively. So for that kind of drug, the volume of distribution will be low. The more your drug bound with plasma protein, it's confined to the blood vessels. It cannot go to other compartments. So when it's confined to the blood vessel, the volume of distribution is low. Okay. Then the tissue storage. When a drug is goes and deposited in the other tissues like retina, fat and other parts, they have the larger volume of distribution because they are not inside the blood vessels. They go to other compartments. So what is redistribution? Redistribution is simply you are getting a shot of IV. Imagine a drug in the intravascular compartment. So it is a very highly lipid soluble drug. So it from the blood vessel it goes to the other tissues, other area. You are giving only one shot. So with the time, the amount of drug in the blood vessel is reduced. So the concentration here is low. Concentration in the other compartment is high. But it is lipid soluble. So a reverse happens from the other tissues. The drug will come back to the blood. That is redistribution. From the blood vessel, if it goes to the tissues, that is that from the plasma, if a drug goes to the other compartment or other tissues, that is distribution. From other compartment or other tissues, the drug will come back to the plasma according to the concentration gradient. That is we call redistribution. The best example is thiopentine. So just go through this. This is the concept. We'll teach you thiopentine in general anesthesia pharmacology. Then there is something called selective distribution. Few drugs selectively goes and get stored in specific body parts. Like tetracycline goes and store in the bone and teeth, thiopentine in adipose tissue, chloroquine in the liver and retina, digoxin in the heart. The plasma protein and tissue binding, I have explained earlier. Drugs circulate in the protein bound form. That means in the blood, if you give a drug, there will always two form. Some portion of drug is always bound to plasma protein. Some is not bound to plasma protein but still stays in the plasma. The non-bound portion is the active portion that is participated in the action of that particular drug. The drug which is bound to plasma protein, it's in the storage form. So in the circulating blood, the drug is found in the protein bound form and the free form. The free fraction of the drug is pharmacologically active. Meantime, the protein bound component is a reservoir. When the free or the active part is part or activated on the action and it is reduced, these bound or reservoir part will slowly reduce to the plasma and it will continue the action. Free and bound fractions are in equilibrium and the free drugs removed from the plasma by metabolism, renal function or renal dialysis is replaced by drug released from the bound fraction. So when the free portion is reduced, your reservoir or the bound portion will release the drug as a free form. Albumin is the main binding protein for many drugs as it is a common plasma protein. So, how the plasma protein binding of a drug influence on pharmacokinetics? When a drug is extensively bound to plasma protein, it will stay inside the plasma or blood vessel. So the volume of distribution is reduced. When it's bound with because the free portion of the drug is goes to the liver and get metabolized. When it's bound with the plasma protein, the metabolism is delayed. And when the plasma protein bonds with the drug in the kidney, the filtration is difficult because it is larger molecule. So the excretion also reduced. When the metabolism, that means inactivation or deactivation of the drug, is reduced and the excretion is reduced, what happens? The active part of the drug or portion of the drug is stays more in the blood. So the duration of action is prolonged. So large or huge plasma protein bound of the drug will prolong the duration of action. Okay? And when it's bound extensively to the plasma protein, sometimes it makes difficulty of removing the drug by hemodialysis. So when you have low plasma albumin level, so there is an increase in the free form of drug, like in the liver disease, because liver is the one which produce albumin, plasma protein. You don't have enough plasma protein to bind with drug. In the kidney disease, you lose albumin in the urine, albuminuria. There is not enough albumin in your blood. So there is no enough plasma protein to bond with the drug. So the proportion of the active form of the drug is increased or the free form increased. So it will give drug toxicity. So in the patient with chronic liver disease, chronic renal failure, if you give a drug which you are going to give to the normal person, they will develop toxic effect. So that kind of person, you have to reduce the dose of your drug. That is for that we are learning this pharmacokinetics. You know what are the drugs bound to plasma protein. So when there is a liver disease or kidney disease, there is no enough amount of albumin in the blood. So there will be free more active drugs. So in that kind of person, you have to reduce your dosage. So they will not get toxic effect. Okay. If you think why we want to learn these things, the pharmacokinetics, to get an idea about the disease and how the drugs work. Then there's a blood-brain barrier, triple B. It is lipid soluble and ionized, unionized form cross easily. But during the inflammation, what will happen is the BBB, triple B barrier is disturbed. So the water soluble substance, drugs like penicillin also enter the brain and work. That is a good thing for your body. Like usually penicillin is water soluble, so it will poorly penetrate the blood-brain barrier. When there is a bacterial meningitis, the blood-brain barrier is affected. So these poorly penetrable penicillin goes to your brain and it kills the bacteria. So this is just a diagram. You all know this. I'm just going. And then again, placental barrier. There are lipid membrane between mother and fetus. So again, unionized and lipid soluble drugs freely crosses the placenta barrier, like anesthetics, alcohol, and morphine. Okay. That's why we don't usually pump the pregnant mother with morphine, alcohol, and anesthetic because that will go and affect the fetus. Teratogenesis. The process of causing deleterious effect in the fetus when a drug crossing the placenta. Like thalidomide. Thalidomide is we are not using nowadays. That is a dangerous drug. I think I have explained this during my drug development. No, I don't know. The safety and the safety of the drug. The tetracycline causes yellowish discoloration of the teeth. Antithyroid drug, when the mother takes, it processes the placenta, it goes and it will suppress the fetal thyroid gland. So Baba will not produce enough thyroxine for itself. Some teratogenetic effects are up to 16 weeks. Up to 16 days, that means 2 to 3 weeks of POA, it will cause abortion. 2 to 8 weeks, it will affect organogenesis and structural abnormalities. Second and third trimester, it may affect the growth of the fetus. This is one question you just go through. I had few other questions when we meet you live on site. I will be interacting with them. Okay? As I always say, may peace be upon with you. And thank you for being with me. If you have any doubts, you can always free to mail me or contact me via the WhatsApp. Okay, student, have a nice day. We'll meet you at Pharmacokinetics 2. Have a nice day.